So we will today go through the neuro-ophthalmic emergencies. There are five main neuro-ophthalmic emergencies, and they can present with only visual loss, ophthalmoplegia, or both vision loss and ophthalmoplegia. If it's just a vision loss, we have to think about giant cell arteritis. Giant cell arteritis. If it's ophthalmoplegia, we have to think of intracranial aneurysm, which can be ruptured or unruptured, or we have to think about cavernous sinus thrombosis. When there is decrease in both vision and there is ophthalmoplegia also, we have to think about orbital apex syndrome or the pituitary apoplexy. In giant cell arteritis, when there is just a vision loss, if there is a sudden decrease in vision, what all can be the DDs? It can be AION, it can be CRAO, it can be choroidal ischemia, it can be posterior ischemic optic neuropathy. It if the patient is presenting with vision loss and diplopia but with no ophthalmoplegia, we have to rule out cranial nerve and associated nuclear infarction or extraocular movement infarctions. We have to ask about the history of headache, which can be unilateral, any jaw claudication, and several and more than three systems involved. And then we can think of GCA, giant cell arteritis. How to make the diagnosis is to ask for clinical signs and symptoms. We have to do labs. We have to do ESR, CRP, and CBC. CBC might show normocytic anemia and thrombocytosis. ESR normal to ages in males age divided by 2 is the normal ESR, and in females age plus 20 divided by 2 is the normal ESR value. The gold standard to diagnose giant cell arteritis is a temporal artery biopsy, and the size of this temporal artery biopsy should be minimum 2 centimeters so that we can account for any skip lesions. When the giant cell arteritis is diagnosed on biopsy, we have to start the patient on oral methylpred at full dose, that is 80 to 100 milligram per day, and this dose might be needed for around 1 to 2 years also. And we have to start on IV steroids in pulse dose in between. ESR has to be repeated every 4 to 6 weeks if it is diagnosed as GCA and the patient is on steroids. What can be the DDs for it? It could be inflammatory optic neuritis. Second DD can be an compressive tumor. The third DD can be diabetic papillophlebitis, and the fourth DD can be CRAO or CRVO when there is a vision loss. When the patient presents with only ophthalmoplegia but not vision loss, then we have to think of intracranial aneurysm. And intracranial aneurysm can happen either in a ruptured form or unruptured form. And the rupture form of intracranial aneurysm is mostly 85% found in posterior communicating artery. In this category, if the vision loss is there, we have to look for the ophthalmic artery aneurysm. If the patient is cortical blind, we have to look for any basilar artery aneurysm. If there is ophthalmoplegia, we have to look for circle of Willis aneurysm or cavernous sinus aneurysm. In these patients, complete unilateral ptosis can be present. Their eye can be abducted, and proptosis can be present about 1 to 2 millimeter. Aniscoria is there, and this aniscoria is increased in bright lights. There can be frontal head pain, and the patient might, if the patient has ophthalmoplegia, the patient might present with pupil involving third nerve palsy when posterior communicating site is involved. How to diagnose these intracranial aneurysms? We have to do MR angio and CT angio because uh, because and we have to do MR angio and CT angio because the other CT scan is around 3 millimeter. So we have to do 1.5 millimeter scans because intracranial aneurysms can be missed at more than 3 millimeter scans. And what else we can do is digital subtraction cerebral angio when there is gold standard is digital subtraction cerebral angiography. In it, unruptured aneurysms, we can treat them with direct or open surgery by clip at the base of the aneurysm, or we can do an endovascular procedure using a catheters, that is the balloons and the coils. What are the DDs for the intracranial aneurysms? It could be microvascular or ischemic lesions, epidural or subdural hemorrhage, meningitis, hypertensive crisis, and migraine. If the patient is presenting with ophthalmoplegia, we have to remember cavernous sinus thrombosis. Patients in cavernous sinus thrombosis present with eye pain, orbital congestion, proptosis, adnexal edema, that is the lid edema, ptosis, ophthalmoplegia. Sixth nerve is involved more than third or fourth nerve. Trigeminal nerve, first and second branch is also involved, and the patient can be febrile and there can be nausea and vomiting. First it's unilateral, then it's bilateral. And in cavernous sinus thrombosis, what investigations can be done? We can do orbital CT without contrast and MRI with fast fat suppression. And the contrast enhanced scan has to be done both in axial view and the coronal view. Mostly in cavernous sinus thrombosis, ethmoid is involved more than sphenoid and maxillary. Cavernous sinus thrombosis can be septic or aseptic. In the septic variety, we have to start the patient on antibiotics, anticoagulants, corticosteroids. We have to debride the sinuses. We have to start amphotericin B, and we have to do metabolic acidosis correction. In aseptic thing, we have to treat the underlying disease and start on anticoagulation. When the patient presents with the both decreased vision and ophthalmoplegia, we have to consider two things, that is the orbital apex syndrome or the pituitary apoplexy. The orbital apex syndrome, there is no pain. In contrast to cavernous sinus thrombosis, there is little congestion. Proptosis is present oftenly. The adnexal edema is very little. Ptosis is there. Ophthalmoplegia is mostly complete. There is reduced corneal sensitivity. Vision loss is early compared to the cavernous sinus thrombosis. There is RAPD present, and HR can be present rarely. In orbital apex syndrome also, we have to do orbital CT without contrast and MRI with fat suppression, and we can do contrast enhanced scan in axial and the coronal views. In orbital apex syndrome, the same management we follow as in the cavernous sinus thrombosis by dividing it into septic or aseptic variety, and we have to add for mucormycosis any sinus exentration and orbital exentration procedures. And the DDs for the cavernous sinus thrombosis and the orbital apex syndrome are Tolosa-Hunt syndrome, which is a painful condition. The arteriovenous fistula, which is not a painful condition, and the thyroid eye disease. All these DDs are because of proptosis, and Tolosa-Hunt syndrome is because of pain. When there is both vision decrease and ophthalmoplegia, the second thing we were considering is pituitary apoplexy, in which the patient can present with meningeal irritation, gland hyperfunction, and less libido. There is a painful ophthalmoplegia, there is a vision loss, visual field defects, RAPT can be present or not. Other lab features can show decreased sodium, decreased thyroid levels, and increased cortical levels. MRI is the gold standard and it is more sensitive than CT in pituitary apoplexy. How to treat pituitary apoplexy? We have to think of transsphenoid decompression, and in the patients having the neuro-ophthalmic symptoms, we have to think of bromocriptine if there are no neuro-ophthalmic deficits, and we have to supplement with the pituitary hormones. What is the DD of the pituitary apoplexy? Is the intracranial aneurysms. So these are the five main neuro-ophthalmic emergencies. They are not urgencies but emergencies, and in these we have to uh, do the patient workup very fast, and accordingly refer to the neurosurgeon whenever needed.